Hi, everyone. I'm Jack Cush with Room Now. I'm joined by friends of the Autoinflammatory Society. We brought together people who are very interested in Still's disease, autoinflammatory disease. I'm joined by Bella Mehta and Olga Petrina from New York City, and Michael Umbrello from the NIH, and we're going to talk autoinflammatory. So let's begin with Bella. Bella, and I want everybody to sort of tell us your favorite presentation at the meeting, and let's see how that sort of impacts the rest of us. Bella?
Hi, so thank you for having us here. And I really liked one of the abstracts. It's a randomized control trial for Anakinra in Still's disease. And it's very difficult to do randomized control trials in these sort of rare diseases. So they had a placebo arm, a control arm, and they also looked at a time point for 2 weeks. This is a daily injection. So at 2 weeks, they looked at the ACR 30 responses and no fevers. And pretty much everybody who was in the treatment arm reached that ACR 30. And they also followed these patients over 12 weeks. And everybody at least reached an ACR 70, if not an ACR 90. Which was one patient who didn't, and none of the people in the placebo arm reached any of the endpoints of the study. So I think it's an important study because first we're demonstrating, I mean, all of us know that there is IL-1 pathology in Still's disease, but this is a good demonstration of how, how it compares with the placebo. So I think it's an important study.
So these were adults or children?
So there were a few adults and a lot more children. So in the 12 patients that were in the trial, 9 were adults and 9 were children and 3 were adults.
Very interesting. So one of the biggest problems in these trials, and I'd be interested in everybody else's opinion, is outcome measures. So what was brilliant about this study was a 2-week outcome measure, which is really what it takes to control systemic disease. 2 weeks is not enough to control arthritis. But yet the outcome measures for these trials has been the ACR 20 or the JCR 30 and no fever. How are we going to handle this? Michael, you run a Still's clinic. If you were designing a trial, what would be your primary endpoint?
I think it depends on when you initiate therapy, because I think that there's emerging evidence in the systemic JIA Still's arena that when you treat early, you actually improve outcomes. You can even avoid developing arthritis, or especially chronic arthritis. And so perhaps if you're treating early prior to the onset of frank arthritis, just looking at amelioration of systemic inflammation is the good primary endpoint. If you're entering later, once the arthritis has developed or become ingrained, then maybe you need to start to look at other outcomes. But perhaps we need to move away from the hybrid arthritic outcomes that come from rheumatoid arthritis and other arthritic disorders, and think about this early as more of a purely autoinflammatory phenotype.
Exactly.
True. I think that's a very good point, but there's a practical aspect to it. So a lot of Still's disease patients that I see, they come in pretty late. So even the diagnosis is a problem. So it takes 2 or 3 months referral to referral, going to ID. I don't know, like a lot of other physicians before they actually see somebody and get a diagnosis. So that's a delay that we all need to sort of educate and make sure that the patients are referred early.
I think you're exactly right about that, Bella. I think that in the pediatrics community, there's earlier recognition of these fever syndromes or recurrent fevers, whereas in the adult community, there's more causes or more possible explanations. And so people don't get recognized as pathological fever not related to an infection.
True. I mean, I have patients who come in with like PET scans and bone marrows and all of this whole slew done before like a ferritin level, right? Or like something simple. So I think there's a delay of diagnosis, which is also, I hope we address that.
Well, I think that it is helping. The pediatric community has come up with some guidelines for what we might call active systemic disease and ways of quantifying that, and using some of those tools and incorporating those at least as secondary outcome measures might help clinical trial design in the future. Let's go on. And by the way, if everyone, whoever's talking should have their mic on, whoever's not can have their mic off, that will give us better sound. So Olga, what was a standout for you?
So I was actually very interested in the measurement of outcomes or change in outcomes in Still's disease and complications of Still's disease. So I particularly like the abstract speaking about implementation of evidence-based guidelines for treatment of macrophage activation syndrome and HLH. And we all know it's a very serious complication, often leading to mortality in patients when it's not recognized early on. So in this particular abstract, authors from Boston Children's Hospital developed and implemented guidelines to how diagnose and treat MAS early, and it made a huge difference. In their studies, they show that actually post-implementation of the guidelines, the time to diagnosis was shortened from 8.5 to 3 days. Their hospital stay and time to treatment shortened significantly as well. And most importantly, their survival rate improved tremendously. So from initial 75% survival rate, they went up to 93.3% survival rate. I think it's a huge improvement, and it's a very important way of approaching this condition to change the outcomes. Also, when it comes to treatment options that they used, it changed also with the guidelines. So when patients were diagnosed and treated early, they tend to use like IVIG more often, they used Anakinra more often. So it was more targeted therapy rather than dispersing on blanketed immunosuppression. And it also probably contributed to better outcomes in those patients.
Really interesting. You know, obviously HLH like MAS, high mortality rate. Earlier diagnosed, the better they're going to do. So this makes a lot of sense. I think maybe the greatest thing, I think it's great that we have these criteria because then it gives you something to teach with. But I think it's index of suspicion and awareness that really makes the big change here. Having a center interested in this and studying this, they showed the obvious benefits, but now we need more centers to be aware of this and study this. Who else is plagued by either MAS or HLH?
Right. And I also believe that, now that we use so much technology and medical records in our patient care, it's so easy to actually set triggers. Let's say high ferritin levels, fever of unknown origin. If you put those flags on medical records and it brings up those patients who may be at a high risk for MAS, like you can easily pick them up and treat them early. So it's very much doable these days.
And that is certainly an approach that's being implemented by a number of people in the pediatric rheumatology MAS community, is just having a hospital-wide or a system-wide flag on ferritin, for example.
Right.
I guess, again, pediatric community is much sort of ahead of the curve compared to the adult community. Even even right now, it's so difficult for the ICUs to set up such protocols. And even though ICUs see much more MAS than, say, probably an ER, but still, I think the referrals come in a little later than what we think they should.
All right, that's excellent. Michael, what caught your fancy from the meeting?
So there was an abstract at the meeting that was particularly interesting to me, and it was a poster, so it might have been overlooked by many people. This was a poster out of Fabrizio Di Benedetti's group presented by Mariana Rossi. It was poster number 172. And this poster has potentially real implications for personalized medicine in Still's disease. 2 years ago, my group and I identified a set of SNPs in the IL-1 receptor antagonist IL-1RN promoter that correlated with the level of expression of that gene. And we found that the low expression form of the haplotype conferred risk of disease, but that people who had the high expression form of the haplotype actually didn't really respond to treatment with Anakinra, had a very large odds ratio predicting non-response. So we thought that this was important for therapeutic biomarker and potentially identifying the specific correct treatment for people. A German group in March of this year published their cohort study where they were unable to replicate our finding. They found that there wasn't an association of these SNPs in their cohort. And furthermore, there wasn't a relationship with treatment response. And so we were a bit saddened by this possibility because it was very promising. This is an important thing, identifying the correct first treatment in people with systemic JIA. So the group from Rome, Fabrizio Di Benedetti's group, they looked at a big cohort of patients who they had treated in a relatively standardized way, and they looked at the outcome. Their specific outcome was to identify individuals who had disease-free conditions on Anakinra without glucocorticoids. And what they found was that there was a strong correlation, first of all, between these SNPs in the promoter region and the blood levels of IL-1RN mRNAs in the patients. So we hadn't looked in the patients before. So they demonstrated that this follows through in the patients. Second, they found that early treatment, independent of anything else, just clinical early treatment within the first 3 months of disease, positively correlated with better responses to Anakinra than treatment after 3 months of features or diagnosis. And finally, they found that people that carried one or more of these high expression alleles had a 6-fold higher risk of non-response to Anakinra treatment as compared to people who had none of those alleles. This was independent of all clinical risk factors. So this is important because this validates the possibility that we can use genomics to identify the people who aren't going to respond to IL-1 mediated therapy and can initially choose IL-6 directed therapy, or perhaps IL-18 or interferon gamma directed therapy, or even in the future IL-18 directed therapies.
Did they see, or has anybody seen that the ones who are non-responders because of the high expression SNPs, that they're more likely to have more severe disease or progress to MAS?
They didn't identify a correlation in their study of either severe disease or macrophage activation syndrome. I haven't seen their work published in its final form, but in the abstract, I didn't note that. And in our cohort, the clinical data that we had weren't granular enough to really identify that kind of a correlation in a small group. And that's part of the problem, is that these are relatively small studies, 40, 50, 60 patients stratified into a responder and a non-responder group.
Well, this is important because I think that rheumatologists, adults I can speak to, are very habit driven, and they tend to play the same card, and some of them are still playing a TNF inhibitor card after prednisone, and then there are others who, because of like the IL-1, IL-6, they're more familiar with IL-6, they'll use IL-6 first, whatever, and I like the idea that people are going to get early aggressive treatment. I'm worried about there's indiscriminate use without any real guidance, and something like this could be really a big advantage.
I agree. I think that opening the door for using the right treatment in the right person at the right time, early being the right time, genetics defining the right treatment, is the way that we make the most people better with Still's disease.
So this was, Michael, this was only adults, only pediatric, or even some adults in the study?
I believe that this was all children in this study.
We saw this, a group of mine that were reviewing abstracts, we saw this, and of course we're drawn to the authors on the paper. And I think that I couldn't convince my colleagues that this was really important for, this relatively unusual rare disease, but this still could be very, very important. But I think it'd be really exciting to look at the full paper. And now, as you develop more colleagues and collaborations, this would be a very interesting thing to take forward. Very cool. I want to end with the VEXAS syndrome, and not because I live in Texas and can now accuse the authors of misspelling their syndrome. But the VEXAS syndrome was, as you know, recently published in New England Journal. It's a new, linked condition where we now know that somatic mutations of UBA1 has a clinical correlate. And I heard about this. I heard some rumblings about this. My partner said something about the New England Journal paper, which I hadn't read. And then I went to this session that Dan Kastner presented on, which was called Undifferentiated Autoinflammatory Disease. And I thought, well, this will be good. And it was good. The whole session was fabulous. And I think that Dan was more demonstrative than usual and played this super sleuth role about how this whole thing played out. And it started with one patient and then 3 patients. But the idea was that these patients had an undiagnosed condition. One underwent a bone marrow biopsy. The pathologist looked at the bone marrow biopsy and was scratching her head saying, I've seen this before. I don't know where. There are these vacuolar changes in these bone marrow cells. Come back on Friday. And came back, Dan and team came back on Friday, and now she had 2 more cases. And she said, you look these people up. They have the exact same disease as this man. And sure enough, they did. They all had, 1, a clinical syndrome, which was similar. 2, they had the same UBA1 somatic mutation. And the question was, what is this all about? They did further study, found 25 patients at the NIH who had the mutation. They're all male. They're all middle-aged. A lot of them had relapsing polychondritis or Sweets-like syndrome or something else. What, Michael?
Well, so relapsing polychondritis, a lot of them had been considered to have relapsing polychondritis because they had the presence of chondritis. But in retrospect, if we pull out the retrospectoscope, none of them actually have tracheal inflammation, which makes them not exactly like relapsing polychondritis. So it's this kind of chondritis overlap. I'm sorry to have interrupted. But
that's a really important point, because the constellation, again, it's male, middle-aged, fever, rashes that are neutrophilic-like rashes, neutrophilic-like pulmonary involvement, chondritis, increased risk of VTEs, venous thromboembolic events, and then these bone marrow macules. And they have been diagnosed with everything from myelodysplasia to polyarteritis nodosa. And so it became the VEXAS syndrome, V for vacuoles, E for E1 ubiquitin activating enzyme, X being X-linked, A autoinflammatory, and S somatic mutation. If anything, it's a nice session to watch because it plays out in a very theatric kind of way. And while this is going to be a very rare syndrome in the world of autoinflammatory, I think, maybe not so quick.
It's not clear how rare this will actually be. The fact that they were able to find so many cases just on a quick review of a couple of cohorts suggests that maybe it's more common than we thought. The phenotypic heterogeneity that's seen within this spectrum of people bearing that mutation is the most striking thing. When David Beck went for genes that had somatic mosaicism in the absence of any specific unifying phenotype, that's what enabled him to find this, was that he went for the gene. And so there's a number of different phenotypes. It's not clear what defines which different group these individuals fall in. But my wife, Amanda Umbrella, who's the staff clinician that runs the fever clinic with Dan Kastner, she noted that these were her sickest patients by far across the decade that she's worked in the group. So when it became apparent, there was a cluster of them that she immediately was able to recognize that would have the same mutations because they were just so sick in the same way.
And what I also find very peculiar is the association of autoinflammatory syndrome with myelodysplastic syndrome. We usually see myelodysplastic more in autoimmune disease, while in autoinflammatory is polycytosis, unless we go into MAS, of course. So that's a very interesting, something not we really see in autoinflammatory conditions.
Wow.
Makes it very unique in a way, I would say.
I want to end with one, I think it's I hope it's not too commercial, but the idea is this year we adults had a milestone with canakinumab being approved for adult Still's disease, largely based on an arthritis clinical trial. And I think we all have our own patterns of how we use IL-1 inhibition in patients that are going to be diagnosed with Still's disease. I'd be interested in the other authors, investigators here telling me how you use IL-1 inhibition in your clinics. Do you still want to go with the shorter acting drug? Has these indications? It's been approved for systemic JIA for a while now. Michael, how has your use of IL-1 inhibition changed over time?
So within kids, I generally like to observe with Anakinra first, and a lot of that has to do with practice and habits. But the thought is that it's quick on and it's quick off. So we're going to see quickly if it works. And if it works and we need to make a switch to a longer acting IL-1 blocker, then we can switch to canakinumab at that point. But if it doesn't work, we can rapidly titrate the dose upwards to a maximal dose where we would expect response if we were going to see it. And then we can switch at that point to another drug. Within the adult community, there's been some resistance, and at the NIH, canakinumab is not on the formulary. So we would still use Anakinra as a first agent and then try to interface with insurance companies to get canakinumab to give on top of that.
Olga, what's changed for you over the years? You were using Ilaris like long before anyone else I know, but what's your approach when you're a newly diagnosed patient?
Yeah, so it depends on their severity, of course, and I try to start IL-1 inhibitor as early as possible because it really makes a huge difference in their treatment course and then in their outcomes. My approach usually is what I can get earliest, and it truly depends on what we have on formulary in the hospital, if it's inpatient patient, or what insurance prefers as the first line. What I've noticed lately that when it comes to outpatient approvals, canakinumab is getting easier to get approved. So I have less resistance from the insurance companies to get approved, so we can get started early. But still, Anakinra seems to be the easiest one to get first. A lot of times we still go to Anakinra as a first line. I feel like rilonacept and Ilaris provide better coverage for my patients just because they're longer acting IL-1 inhibitors. And I have a feeling that even if we start with a shorter acting one first, most of the time I tend to proceed with a longer acting one later on, either rilonacept or canakinumab, whatever we can get approved later on.
Bella, how does that sit with you?
I think inpatient, pretty much 100% Anakinra, just because you want to see the, formularies, like policies and whatnot. Outpatient, I think a lot more canakinumab than Anakinra, because eventually I feel like even the people who need it, I mean, either some patients don't need a biologic and, maybe they're just okay with a little bit of prednisone or methotrexate or something. But at some point or they're severe enough that I've decided they need some sort of biologic, if I can get the insurance to approve the canakinumab, that's easier. If not, then you go through the Anakinra route. But it's a lot more insurance driven than us driven in some sense. But maybe yesterday, like these days, it's getting better. It's easier to get the canakinumab.
Well, the FDA approval will help. And, honestly, the study that you reviewed today, if that gets published, that'll help because it helps you get, Anakinra paid for when the insurance doesn't want to pay for that. So anyway, great discussion. I want to thank the panelists for bringing forward their views of the meeting. We'll talk again next year.
Thank you.
Thank you.